Good afternoon, everyone, and thank you for joining us today for our fourth webinar in our SUD series. Today, we're going to be covering the application of the harm reduction model for SUD patients. Before we get started and I introduce you to our speaker today, I have a few housekeeping items for you. Please keep in mind that all of the lines will remain muted to avoid background noise. This presentation is being recorded and it will be posted on our website after it takes place. Please type any questions that you have into the Q&A tab. More than likely, we're going to address those at the end, but if you have something very pressing, please feel free to type it into the tab so that you don't forget what your question was. And then after the presentation, we will provide a link in the chat for the survey to the post-training evaluation. So please complete that so that you can, it'll ask if you'd like continuing education credit. And if you would like that credit, just please be sure that you're attending at least 95% of the training. So you'll receive that link in the chat. It'll be posted on the screen. And then you'll also receive an email from our training team following the training. Our evaluations also help us to understand what areas we can improve for our trainings and what different topics that we can offer in the future. So please, if you have the time, please fill that out for us. Lastly, here in housekeeping, I'd like to thank our funder, Maricopa County Department of Public Health, and KHEC for providing us with continuing education credit. And with that being said, I'll introduce you to our speaker for today, Joshua Leslie. So I'll allow Josh to say hello.
Hello, everybody.
Thanks for being with us, Josh. So I just wanted to provide a brief introduction to Joshua Leslie. He works closely with some of our health centers under the Maricopa County Overdose Data to Action Grant as a consultant. He's a certified physician's assistant, and he's worked in substance use disorder treatment and psychiatry since 2006. He was recently named the top physician assistant in America by the Point of Care Network for his dedication to patient care and for providing opportunities for other PAs in the field. He is amazing at the Alliance. We're well aware of that, and many of our centers are as well that he's done work with. So I'm excited to be having him share this presentation with you all. And with that being said, I will hand it over to you, Josh.
Well, thank you, Janelle. Appreciate that. Hello, everybody. We will get started. And I will give you a little bit of background. Let's get this going. So as Janelle said, so I'm a PA. I've been working in psychiatry and substance use disorder for about 15, 16 years now, and providing kind of a more unique perspective on harm reduction. I actually was trained to not follow the harm reduction models. This is a very different approach, and my if anybody has worked with or knows how PAs work, there's a lot of on-the-job training. Back when I first started, this was not recognized within the programs that I had worked in. This was not a model that our program had really bought into, and so I spent several years actually looking at things very differently. And it wasn't until I'd say about halfway in my career where the harm reduction model was starting to be introduced on the clinical side. There was a lot of skepticism around it. There was a lot of fear around it. As a trained behavioral health medical provider, one of the things that you're taught to do or educated or trained to do is to, quote unquote, protect your license. And this is a scenario in which I think is probably well shared amongst the group that's here today, and is one of the primary fears around looking at the harm reduction model. If you know, document that this individual or these our patients are doing X, Y, and Z, but yet you're prescribing medications that could have interactions with those illicit substances, then you just can't do that. And that was always the model, and that was always the education and the training. That shift has occurred, and I will tell you on a personal journey, having to work within and experience the negative outcomes when you don't treat towards the harm reduction model. And the fact that even though your documentation may look great, and you're following what you believe are the right practices and procedures associated with your organization, uh, patients are dying, and on a very alarming level. And by utilizing these techniques and utilizing this model, we're able to reduce those numbers substantially. And so I've become very passionate about this. I own an organization called Ascend Healthcare. We actually partner with large entities to build programs for them. We implement the policies, the procedures, the operations, the staff, so that more patients have access to the resources that they need. And so today's presentation will be talking about the harm reduction model, looking at it as an overview, really identifying the 8 core principles and seeing where you're at as an individual and then where your entity is within those guiding principles. And then what it would take to get to that level. And then once that level's been achieved, what options are out there? What harm reduction programs are available? What are kind of some of the newer things that are coming through into the market now? And then lastly, really talking about, having some open engagement, open forum, questions, discussion. I think we learn best through the actual interaction. I know that doing virtual webinars can be a little challenging, but we really want to open that up to lines of communication. Again, I've been clinically in the field for 15 years and have seen everything and anything that's there. Spent a lot of time in psychiatric crisis centers, a lot of time working in OTPs, opioid treatment programs, methadone, Suboxone, you name it, I've seen it. And so this is an opportunity to really engage with you guys on any questions that you may have, experiences. I do a lot of education and training around shifting culture into what the harm reduction model is and how you get there. And so hopefully this is a valuable webinar at the end of it. So a couple of things. First, what is the harm reduction model, or really what are we looking at? And it is a set of 8 principal strategies that's aimed at reducing the negative consequences associated with drug use. It's an overall interpretation of it. It's having a belief in and a respect for the rights of individuals that are using illicit substances. And illicit substances. Harm reduction demands and interventions and policies are designed to serve those that use drugs in order to reflect specific individual and community needs. And that there is a broad spectrum of strategies associated with harm reduction. And that, I think, is really kind of the key takeaway of anything that is picked up or educated on today, is that no one strategy works for every individual. And you have to look at everything on a case-by-case basis. I think a lot of the questions that I get over the years around this is, well, what's your policy around this? Or, well, when somebody has their 3rd positive drug screen, what do I do now? And well, someone had this, so now what do I do? Harm reduction really teaches that there's an entire spectrum of strategies that you're looking for, but understanding what the overall principles of treatment are and the overall principles of acceptance are is going to be really important, and truly focusing on where patients are at and how do you get them the best care that they can receive, but then also the care that they want to receive. And so it goes both ways. I am going to spend some time talking about those specific 8 strategies. I'm not a huge PowerPoint person. I don't like reading from slides, but those are kind of the key elements to the entire presentation. So we are going to go through those with you today. The first strategy, the first acceptance is that, for better or worse, illicit and illicit drug use is part of our world. And we choose to work to minimize its harmful effects rather than simply ignore or condemn them. Again, I can tell you that from my clinical practice, that I think is one of the primary core elements of understanding. My previous training was around either don't ask the question, or if it comes up, we got a problem, I can't keep treating you, you need to get help somewhere else, this isn't the right place for you. And that is absolutely not acceptable care, and understanding that we are creating more harm by presenting and by practicing in those realms. Number two is to understand that drug use is a complex, multifaceted phenomena that encompasses a continuum of behaviors from severe abuse all the way through to total abstinence. And it's also acknowledging that in some ways of using drugs are clearly safer than other ways. And we'll talk about that in more detail. Number three is to work to establish the quality of an individual's life and their well-being, not necessarily cessation of all drug use. And that is really another important key component to this. We see a lot of programs that are abstinent based. And although those programs can be successful for some individuals, it is not a guiding principle of harm reduction, and that the criteria for successful intervention is around individuals' quality of life and well-being improving. Fourth is to make sure that we are always practicing non-judgmental, non-coercive provision of services, and that the resources to the patients who use the drugs in the communities will allow them to further reduce their harm. And so, we're going to talk more about some programs that are out there, understanding that we are presenting in a non-judgmental way. We are presenting with available options and resources, and that what fits that individual is really the key to successful outcomes. So in addition, the focus is to ensure that patients routinely have a real voice in the creation of the programs and the policies that serve them. So this is really important. This is an area where I think and I know we have some administrators on as well from an administrative side, you can create everything that you believe to be a phenomenal and successful program, but if it doesn't hit the population that you're working with, and it isn't hitting the individuals that need the help, we have to be able to pivot and to create programs that are successful. Tell you, I was working with a group of individuals, another organization was very, very keen on utilizing licensed independent substance abuse counselors to run their groups, which I 100% support. I think that's great. And then in addition, I love the fact that they were also using a peer support specialist to work with individuals within the group. And they allowed that peer support a few minutes at the end of each group discussion, talk about where they were at, what their experiences were, how they received treatment and care. And this group, over the course of it's about 6 months, we saw a huge initial impact, multiple people attending. And then we just saw the group kind of diminish slowly over time to a point where we started with a group of 12. We would get approximately about 3 or 4 additional new individuals in every week. But by the end of 6 months, the group had diminished down to about 4 or 5 members. At that time, I was an administrator and had walked into the group and was wondering what was going on, spent some time talking with the group members, and found out that our licensed independent substance abuse counselor just did not have that same level of connection that our peer support specialist had. We made the adjustments. Our peer support specialist began, in essence, running the group with the assistance or with the oversight of the licensed independent substance abuse counselor. Word got out, word spread. To this day, that group is the most successful group that exists, averaging 12, 15, sometimes We have to push it up to 18 individuals in the group at one time. And so this is a really important component of harm reduction, allowing individuals to have a real voice in what's going on with their programming and making sure that it does serve them and their needs. The next principle is to affirm that our patients are themselves the primary agents of reducing harm from their drug use, and seek to empower our patients to share information and to support each other in strategies that meet their actual conditions of use. Another very important area. I think probably the number one most common question I hear is, how do I help someone that doesn't want to help themselves? And that is where the harm reduction strategies become extremely important. And focusing and having a conversation with the patient around that they are the primary agent of change, that there's patient activation in what change looks like. And maybe change is small, and maybe change is not what I or you would expect, but what is the individual, what is the patient saying that they can achieve? And once they've hit that goal, what's the next goal? So it's really important that we look at that area of change and showing those successes. Maybe they're little. Maybe it was, hey, doc, I got a shower today. It's the first time I showered in 3 months. That's a win. It's a huge win. Okay. So now where do we go from there? Right. So those are things that are really important on the harm reduction side and the core principal element. Next is to be fully observant and aware the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequities that affect both our patients' vulnerability to and capacity for effectively dealing with drug-related harm. One of the core elements, and there's some slides that we'll talk about here, around making a change is the social determinants of health, identifying the factors that are pressing against your patients and pressing against the individuals that are trying to seek the help, and removing those barriers and being aware of those and recognizing those and providing actual input and support to remove that for that individual. And then lastly is that our care does not attempt to minimize or ignore the real and tragic harm and danger associated with licit and illicit drug use. Having real conversations with patients is very important. Those individuals that are in these programs have a high probability of experiencing trauma themselves or have been witnesses to severe trauma. Having an understanding that those individuals that are entering your programs may have or likely have had an overdose, or have individuals that have overdosed or died in front of them, and understanding that these dangers a lot of times is what brings somebody in, and recognizing and appreciating that side of it. So with that being said, this is really the core element of the entire presentation. We can wrap the presentation up in 15 minutes. If you as an individual or you as an entity are not able to get your understanding or get the culture wrapped around the idea of harm reduction, the next slides that we talk about really aren't very helpful. If you believe that you can get to this point, or you believe that you're open to having this dialogue and working with your staff and working within yourself to understand how important these changes are, then we're able to take those next steps into how do we reduce harm and what that looks like. And so we'll talk and spend a little bit of time around what different harm reduction programs are out there, what's available, maybe what you're able to provide. And then from there, we'll open up to some questions and answers. So the first thing that we talk about are syringe service programs, or SSPs, sometimes called SAPs, syringe access programs. Most folks have heard of these at some point in time. And in essence, these programs offer sterile injection equipment for safe use and a safe location to discard already used needles and syringes. And so there's some really good evidence to support these programs and the growth and expansion of these programs. It's been shown they're associated with an estimated 50% reduction in HIV and hepatitis C incidence. 50% reduction. The majority of the programs offer referrals to medication-assisted treatment programs, and new users that enter these programs are 5 times more likely to enter a drug treatment program and 3 times more likely to stop using drugs than those that don't have these programs or don't use these programs. So we know they're effective. We know that they work. And so then the next part of this slide really doesn't make a lot of sense. Only 33 states in the US operate them. And in that, many cities and states without authorized programs have then had to create and enact formal and informal resolutions to allow them to operate. And again, I think that everyone in this discussion probably has a good idea as to why these are not operated. Right? You're creating a program in which an individual is coming and likely has on them illicit substances and is handing over needles that have been used for illicit substance use. And so the legality around this is very difficult. I'm going to talk a little bit more about Sonoran Prevention Works. I am not a paid spokesperson for them, but I am very passionate about the work that they have done and that they have committed since the organization started in 2017. I usually direct almost everybody over to their website and over to their team about finding out more information that's available within your geographic area for the syringe service programs that might be available to your patients. The next program, probably one of, if not the most important programs that are out there at this point, is naloxone or overdose prevention programs. I'll tell you, one of the things our company does is that as we are teaming up with other organizations and providing and building programs for them, one of the first things we talk about is overdose prevention strategies and opioid use disorder and creating, developing a model for them. And very frequently, I have heard from different organizations, thanks, we appreciate that, but we really don't have an opioid issue. We see more of our folks maybe have methamphetamine issues or alcohol or benzodiazepines, but we're not really seeing a lot of opioid use issues. I would always challenge that, and our data really kind of supports that that's not accurate. So Arizona has the 15th highest rate of overdose fatality in the nation. And so that statement alone usually brings about some change at the program level. And really what it comes down to is screening, identifying individuals, folks that you're seeing every day that maybe you're, within a federally qualified health center and you're screening for medical, but not really taking those next steps into what is going on the opioid use disorder side. And again, before you know it, here's where we're at. And so again, not a paid spokesperson for Sonoran Prevention Works, but I'm highlighting them again. They are the largest naloxone distribution program in the state. Again, so naloxone, for anybody that doesn't know, naloxone is the antidote for opioid overdose. It blocks that opioid receptor and is life-saving. So Sonoran Prevention Works will work with community leaders, they work with individuals, they work with healthcare agencies. I've worked with them multiple times to supply naloxone kits to organizations that they're then able to directly hand out to patients. So far, they've distributed at least 325,000 doses of naloxone since their inception in 2017. And also what I thought was very interesting is that they even offer a mail delivery service. So I added a link to this program. They'll even provide that as a viable option for individuals. And this program alone has had direct implication for saving thousands of lives across the state. So the next thing we're going to spend a little bit of time on is talking about medication for opioid use disorder. Now you'll see tons of different abbreviations. This one's MOUD. You'll see MAT, M-A-T, which is probably the most common term, medication assisted treatment. I actually, for my programs, I use the term MIST, M-S-T, which is medication supported therapy. Big proponent of therapy and pushing the therapy component as far as treatment goes. And so we use the term MIST. I'm just highlighting a few of the medications. We are not going to go through intricate detail. And also I did not put methadone on there either. So methadone is specifically within a methadone treatment center. And for our current participants within the program, 95% or more of the individuals are going to be looking at engaging in services around these three primary medications. So the first is Suboxone, probably the most well-known at this point. It's a partial opioid agonist, so it partially blocks and it stops the high that's experienced from street opioids, and it's prescribed in a once daily dosing. And I think that's really important for anybody that may be kind of new or learning, is that one of the hardest things for someone with opioid use disorder is that they're always chasing that next high, and they're basically trying to stop withdrawal from occurring, right? And so they never get to those highs, but boy, those withdrawals come, and they come frequently. And so what Suboxone allows us to do is to create a long-acting form of treatment that will withhold those withdrawal symptoms or reduce those withdrawal symptoms. And actually, in essence, we're trying to stop those withdrawal symptoms and stop those psychological cravings for an extended period of time. Now, this will range on your patient population, how their liver's affected, those types of things. We're looking for about 24 to 36 hours of relief with a dose. I will tell you that most individuals will tell us that it's about 20 to 24 hours. And then again, it's I could spend hours talking about nuanced around Suboxone. I do let everybody know that Suboxone, because it is a partial opioid agonist, it does also have some physical effects. And so we do educate individuals that if you're going to stop cold turkey and you say, okay, I'm off my heroin use, I'm on Suboxone, I'm stable, I'm ready to go off of the Suboxone. We go through a gradual decrease process with them, in addition to those additional supports, in order to help them get to remove off of Suboxone if that's indicated. The next medication for opioid use disorder we're going to talk about is naltrexone. So naltrexone is a full block, so it will block the opioid from coming on board, and so that an individual is not going to feel anything. There's no gratification around use. And so that is another treatment option that is used frequently within the confines of a good, complete program for opioid use disorder. Coincidentally, it also blocks the effects of alcohol, and so that is an important area to have conversations around with patients as well. And then last, what we'll talk about is Vivitrol. So Vivitrol is naltrexone. It's the injectable form of naltrexone. And it's basically like an encapsulated module that is slowly released every 28 days following, or within 28 days following the injection. There is no withdrawal, so Vivitrol can be stopped at any time. But understanding that the Vivitrol injection, or those encapsulated crystals, will be distributed within the bloodstream over a course of 28 days post injection. And so it's educating the patient on that, letting them know that, if you're using Vivitrol, once you have the injection, it's in there for a month. So in the next slide, we talk about, sometimes this is the most controversial area of conversation. And I would say maybe some of the, especially on the clinician side, this seems to be an area that, that I spend a lot of time educating and working on. And again, changing the thought process around what harm reduction is. I'll give you my story, my spiel real quick. I got time. I got plenty of time. So, I was working as a clinician within an opioid treatment program, OTP. So that's methadone, that's the whole nines. And I have a new, brand new grad that was coming on board, and we were training them, and they had interest in joining the team, and so they're sitting there, they're working with me, I'm working through with them, and I had one of my patients' name was I won't say name. One of my patients came through, and patient walks in the room. I got my student with me, or my new grad, with me, and says, "Hey, Josh, I'm only using meth right now," and gives me a big high five. I said, "All right." I said, "Great job, just meth." And I can see this new grad looking at me saying, "Oh my gosh, what are you doing?" And so I had the patient explain that, they had been, quote unquote, speedballing for years, using methamphetamine and heroin, and had done this almost 3/4 of their life. And so the fact that, and I've been working with this individual for over 6 months to slowly try to get off of all the opioids, work with our medication supported therapy team. And he was so ecstatic that he was finally off the opioids and was using methamphetamine on occasion, a couple times a week, but couldn't be happier. And again, great example of harm reduction in real clinical practice. And looking at the face of the new grad saying, oh my gosh, like, how is that okay? And going through and explaining, we're not using IV drugs anymore. We're not using heroin anymore. He was snorting methamphetamine a couple times a week. I'll take that. It's a win. And so that's, just one of those examples of like, what do we look at and how do we discuss safer drug use with our individuals, again, focusing on overdose prevention. So some of those core areas are obviously really educating, working with use slow, use less, test that strength. If you are going to use IV, please test the strength. There's so much fentanyl that's out there now, and it's being laced within what one would consider a normal dose, and it's leading to so many more overdoses. 2020 was the highest fatality year that we've had for opioid overdose, and so this is a key area. If you can't get your folks to switch from injectable, that's really one of the number one things we focus on. And obviously, one of our biggest focuses is trying to stop the injecting side, trying to stop the IV drug use. It carries the highest risk for overdose. Try any way possible to get individuals to shift. So snorting, smoking, anything to reduce some of that acute overdose risk. You can still overdose through smoking, snorting, but that risk is highly reduced. Next thing we talk about with folks is trying to space out doses. I'll tell you, in clinical practice, that's a hard conversation. Usually we get the head nods. Okay, yep, sure. Okay, I'll do what I can. But again, this is around education and trying to help produce or trying to help keep people alive and trying to reduce the overall overdoses that are occurring. So we can space out the doses. Again, educating on fentanyl and the long half-life associated with fentanyl. It will allow those individuals a better opportunity to not overdose. Other areas, I know they seem like they're common sense, but having an open discussion with your patients, are they using alone? Are they using in a group? I can tell you that's probably not asked very often by most clinicians. So it's really important that you have that conversation, checking on, hey, if you're using alone, do you have anybody that can check on you? Do you have a buddy? Do you have somebody that can check, make sure, if you do overdose, is there someone that's out there to intervene? Next is if they are in a group, really strongly push to try to get use staggered. So we want to make sure that someone within the group is always alert, and that obviously at least one person has naloxone or Narcan on them. If they're in a group, usually we try to encourage that they keep the Narcan out on the table, on a chair, on the floor, somewhere, so that it's readily available for whoever. And then last, and again, I already mentioned this a couple of times through with snort prevention work, is that, carry Narcan. Always make sure it's available. No such thing as giving out enough Narcan. No such thing as giving out enough Narcan kits. And so I think it's just so important. And then educating on overdose. And again, what I think is interesting is that there are some studies out there with Narcan and naloxone that are showing that it could be other overdoses, could be benzodiazepines, could be some other substances that are mixed in, but giving the Narcan can be extremely beneficial and can save someone's life. And then the last slide, kind of last comment here around programs that are out there. And this is in the United States, this is kind of the most controversial program at this point, are what are called supervised consumption services. This is actually fairly common in Europe, but has been a challenge to get going here in the United States. So these are designated sites where people can actually use drugs under the safety and supervision of trained professionals. it's a step further than your syringe programs, right? It's an actual designated area with health professionals, with trained medical staff, with peer support. And they're designed to make sure that drugs are being used safely and under the advisement of, or under the at least the watchful eye of trained professionals. I know in the United States, having this conversation with folks, it sounds highly unusual, but these programs have actually been around for over 30 years. There's at least 120 different sites across 11 different countries across the world. Again, Europe is kind of a bigger proponent. These programs are really phenomenal in the fact that they promote the engagement and referrals to support services. They include housing placements. They include other areas that drug treatment is available and an option to them. And the United States has tried and has made some progress over the last about 5 to 7 years. They have done some testing sites, New York, Seattle, Buffalo, San Francisco, probably missing a few. But really what it comes down to is that there's so many legal barriers to this. And then secondly, there's funding barriers. There's lots of funding out there for reduction of opioid use. But when you start talking about having substances used within your facility but used safely, funding typically dries up. I will tell you that some newer research out there, and actually just last month, I think this is really important. New Mexico passed the House Bill 123, which authorized supervising consumption service locations as a critical public health tool to combat overdose death and to provide a bridge to healthcare, substance use treatment, and social supports. So this legislation in New Mexico, our neighboring state, allows for the use of supervised consumption service sites, and it provided legal protections for the programs and the participants. So that for us is kind of like a game changer in the world of harm reduction. And so more advocacy on the legal side of this will create much more viable options to individuals and keep and save lives. So quick slideshow, and really want to open this up to any questions, answers that I can provide or that we can get for you. Well, Janelle, you're on mute.
Oh, I'm sorry about that. Sorry about that. We do have a couple really great questions so far. A few of our participants had typed in during the presentation. So our first question is, how do you balance harm reduction, engagement in care, and possible DCS reporting requirements in cases where the patient has a child?
Yeah, no, and that's a great question. It looks like Kelly. Yeah, that's a great question. Again, I think we went back to talking about, each individual and what the entire picture looks like, right? You may have some standards and even professional standards, right? That says, hey, there's potential risk to a child here, we have to report, right? It's also having to understand where that individual's at, what's going on, how engaged are they, right? And so each individual has to be looked at differently. So you have someone that is, actively attending your services, right? Actively finding better ways to use safely. Making sure that if they are using, it's not when the child's in the home, or if it's like, say, pills that they're locked up in a safe. Doing all these things, this individual's doing things right, everything right, by the letter of maybe your license, it says, well, I still need to make a DCS report. I still need to have a DCS report out there because they're using drugs in the home and there's a child present. Do the extra work, do the research, right? Oh, wait a second, that child is in the home, but there's always somebody present that's making sure the child's safe and that you're using in another room. Like I said, it's locked up, you're not using intravenous, there's no access to needles. Got to look at each case individually to make and determine that next step in care, or that next step in hey, these are consequences of your action, right? Having a conversation with the patient saying, hey, you're not following, what you need to do to have a safe environment. What can we agree to? Where can you get at? What would make it safe so that we wouldn't have to go down these routes? So having that dialogue with a patient is really important. So, I don't have like a try to true policy or procedure. It's all around that individual engagement, making the decision what's in the best safety. And don't get me wrong, I will tell you that we have had scenarios in which, multiple scenarios in which where the balance on the harm reduction is too great, the engagement with the care is not there, and that yes, DCS is involved, and engaging with the patient, explaining, at this point you're not at a stage where you can keep your child safe, and so that we are making a report to DCS in an effort to make sure that the home is safe. We want you getting better. We'll do everything we can to get you to a point where you are safe and your children are safe. But at this point, yes, DCS does get involved. So again, I apologize. I'm not going to give you a nice clear cut answer, but it is on an individual basis.
Thank you. It's definitely a complex situation. So I really appreciate your approach for individuals. So we just have a comment regarding the acronyms you were using,
Sure.
MIST. That's new for me too. I really like that.
Yeah, I think, and I will say as a profession, like as like someone that's treating clinically, and I think we put too much emphasis on the medication side. So when I'm in practice, I actually remove myself out of that and say, hey, I'm prescribing a medication. Like, medication is not the answer to this, right? Treatment around it and taking those next steps and getting to where you need to be at. The medicine is actually a very tiny component of that. So let's get out of this mindset of medication assisted treatment, or even, and I'm okay with medications for the MOUD. But when we say MIST to folks, and we say medication supported therapy, right? Everything's therapy focused, and this is how we're going to take those changes. We're going to look at your social determinants of health. That's where you see the shift occur. And so, yeah, so last several years I've been using that term, and again, I didn't create the term, so I'm not taking credit. That, and I don't want to misspeak, but that I believe was originally created a program out in Vermont that started using that, and then it kind of grew and expanded from there with it.
Awesome. And then we have another question, and that is Suboxone ever used as a rescue agonist when someone is at risk of opioid overdose? Would it be successful to a point?
Yeah, so no. So the answer is no. We don't use Suboxone as a rescue agonist, and actually, clinically, one of the things that happens is that if someone's using opioids and then we go ahead and want to start or to use Suboxone for treatment, that individual actually has to start going through withdrawal. What will happen in a scenario like that, where hey, they've been using opioids, we're going to try to add Suboxone. What we do is we actually kick somebody in what's called precipitated withdrawal, meaning that they will start to go into an active withdrawal, but it's not a rescue treatment. It's not, oh, we're gonna stop this overdose from occurring, because it's only a partial blocker. And so by the time you try to give enough, that honestly, the individual is not going to make it. And so naloxone, the reason it's so important is that because naloxone is a full agonist and completely blocked, and is not given by mouth, it's given through injection, you get the immediate relief and the immediate blockade. But even with naloxone or Narcan, it's only temporary. And so you're only going to get that relief for sometimes 15, 30 minutes, maybe an hour at most. So we do see a substantial amount of overdose deaths occur because, yes, naloxone was administered. The overdose was so strong and those medications last so long that naloxone helps, and then the efficacy left, and so then the person goes right back into overdose. So that is another common occurrence that happens. And so if you use Narcan, or if you do some advanced education with Narcan or naloxone, you give it and it works, you still got to get somebody into medical treatment, get them into the ER, because there is a good possibility that they could go back into and start all over again in their overdose, even though they hadn't used anymore. Great question.
Thank you. And so someone had asked, without kind of knowing the background of the individual, they had asked, where may I refer a patient for harm reduction therapy?
And that's a fair question, right? It's like, do we have specialists in harm reduction therapy? Um, and really, so harm reduction is the mindset of each clinician. And so, your LISACs, like licensed independent substance abuse counselors, LASACs, yeah, there's going to be some formal training around, but this training is available, and this understanding and cultural shift is available for anybody, all areas, all disciplines. And so, what's more important is, as you're referring patients into care, having an engagement with the clinic or the program or the therapist, saying, are you, up to date or current, or do you practice harm reduction strategies, or do you believe in harm reduction for patients, right? And it is important engagement, and because you want to make sure that you're referring patients to the right programs.
One thing I'd like to add to that is, if anyone would like to email me about specific harm reduction resources, I will put my email in the chat box just so that you have it. If we can provide some more specifics and different research and stuff like that around harm reduction as like a resource to providers or other professionals. So I'll put my email in the chat so that you can send over a message. And then that was about it for the questions so far. I'd still welcome some questions if you have any. Something that I did want to mention is this topic can be somewhat controversial, as Josh had mentioned. In the Q&A of this presentation, there's an option to ask questions anonymously. And so I just want to remind everyone that that's perfectly acceptable. If you have a question that you are kind of worried about asking, please type it in the Q&A and mark the anonymous button. And we can't see who's asking the question. I know that sometimes it can be hard to put yourself on the spot and ask questions about this. So I just want to encourage that if you do have a question that you feel might be controversial, yeah, feel free to do that.
Oh, yeah, Janelle, we have another question. It looks like suggestions around encouraging hospitals, especially with an ER, and then someone that's status post overdose of an opioid. Will they be discharged with an naloxone prescription? Is that a standard practice? At this point, where we're at, and with all the changes and adjustments that we've made over the last several years, it is a standard practice. And so, but remember, even though something's a standard practice, that hey, if there's an identified opioid overdose that you're leaving with a prescription for Narcan or naloxone, doesn't mean that every clinician's doing it. No. So even though that is, you'll see it written in almost every hospital with an ER out there, does it always occur? Absolutely not. Would we like it to occur? Absolutely. The other side, and this is where again, like Sonoran Prevention Works gets involved, but even like our access CMO has already written standing order, right? So you can go to a pharmacy, whether you have a prescription or not, and you can get naloxone. And that will be given to you by the pharmacist. I can walk in there today, grab it. I've done it. Said, hey, I want naloxone. Pharmacist kind of looks at me and I say, yep. And they said, all right, hold on 1 second. They grab you the naloxone and say, okay, thank you. Standing order. It's good. You can grab it, any pharmacy that's out there. And like you said, working with Sonoran Prevention Works has been great. And then, most of the ERs out there are doing that and they're pushing that, but it can always improve.
Thank you. And
Then the other
it looks,
question, yeah, I saw that too. So is naloxone covered at full cost? So there's different versions of naloxone, and I will tell you that some versions are much more expensive than others. The nasal, the mist is very expensive, but yeah. So naloxone, and that's, I guess I'll kind of dispel another myth too. So the naloxone injection, where you draw it and inject it, 100% covered, and actually been some changes. I don't want to misspeak, but I believe the mist is now covered too, or the nasal. With that being said, I think one of the biggest misnomers or things that I hear is like, oh, well, we don't give out naloxone kits because they come with needles. And so I want to just dispel that with anybody that's in the group or has ever thought that. So that is a needle that is injected within the muscle. Okay, big, it's a thick needle. You're doing that to save somebody's life. That is not the needle that you're using to inject drugs with. So I want to make sure that I do some education on that. It's one of the most common things to educate is when we're giving out naloxone kits. First thing I hear, I promise, I hear it every time. Oh gosh, great, we just gave somebody a needle to use. Well, number one, if that was a needle that would work, at least it's sterile, right? That's a win. That's good. Number two, that needle is not going to be what they're going to be using as far as IV drug use. So I like to kind of dispel that for everybody as well. So please, whatever you can get as far as naloxone, take it. And then this question I just see here, I was told by patients that the spray takes longer. Yeah, so the mist, and so you're looking at like milligram dosages and like how it's actually absorbed in the bloodstream. So the mist will hit the blood-brain barrier faster, which is great. But when I use like the IM or I use the injectable form, we can use substantially more. And so it does have variability. Again, what we always encourage is like, listen, whatever you have access to, use it. But that is a good comment and a good question. It's just the mechanism of action is different.
and then Josh, did you see the question? Some programs are requiring a standing order in the organization or clinic to give out naloxone. Is there a policy or law to require this?
No, so that's, yeah, so we see that, and that's like an additive, right? That's an additive from a program or a clinic perspective about having that standing order. And then it also depends on who the regulatory body is that they're talking to. So some groups, so like I do some work with CARF accreditation. And so if you're looking through like an accreditation or accreditation programs, you've got to have standing orders like that within the program of the organization. And again, I'm not like the number one like legal lawyer. I do my research as best I can. In Arizona, I do not believe, and I may be misspeaking, but I do not believe it's an actual specific law that every or policy that every clinic have in there a standing order for naloxone. I think that is not, we're not quite at that point.
Yeah, we've also done some research around this, and that's what we've found is that the state standing order does apply.
Yes.
That a lot of times when clinics and even health centers are developing naloxone distribution programs, that the center itself prefers to just make sure they're fully covered in a sense. And so that's why they do a standing order. It isn't required by law in terms of as of today. So not as of yet. It's covered by the state standing order. And then is there an assessment tool to check agency fidelity to harm reduction principles?
I'd love that. I think that'd be awesome. I think that's absolutely the next step in like the commitment to change. And like you said, identifying, and looking through like your policies and your practices and what are your standards and how do you implement harm reduction within your program. But again, we would rely on some like the regulatory bodies out there. Again, I know, again, I'm going to speak for CARF because that's one that I work a lot with. That is part of what we look for. But at the same time, it's something that not all programs out there are doing that. And again, adding that additional regulatory component is useful, and it's a great referral source to go into. Yeah, the actual assessment tool around like agency fidelity, I have not seen any, nor have I seen them like strongly implemented within other programs.
Thank you. And yeah, we're getting close to our time limit here, but I just want to give one last shout out. If anybody has any additional questions, to go ahead and throw them in the Q&A. No judgment here. We're here to help. We're here to help everybody better understand. So if you have a last minute question, go ahead and throw that in there. Josh does work closely with a lot of our health centers. But if your health center would like to learn more about naloxone distribution in a health center, and things like that, please send me an email and I can provide some resources or information from other centers that have implemented programs within the community health center. And so this question, is there a curriculum you can refer to for hospitals, agencies, public health departments to start with when building up harm reduction programs?
It's one of the things that like our company does is, and honestly, there's no standard format. I mean, there is, right? If like, again, I would actually look, and I think CARF does a really nice job, CARF, as a regulatory body to, in essence, create those curriculums or focus on what those core elements need to be. Trying to work with individual partners, but again, each program is going to be independent, and they're going to have different adjustments to what their policies and their practices are, and how their curriculums build out. And so, it's a lot of engagement with your leadership. It's a lot of engagement on the clinical level. It's deciding, okay, yes, we're going to start the program. Here's how we're going to do it. Outreaching other entities that have those programs, great. Again, Janelle will give my email. I can be an available option as well to have some further dialogue around it in order to get started in the right direction. We want to support however possible. And so if there are programs that are interested, we want to try to give you whatever tools you can to kind of get this moving forward.
Thank you. And yeah, just to complement what Josh is saying, we have resources available to help with some of these things. Like I said, examples of policies and procedures that health centers in our state and in other states have used to implement programs for naloxone distribution. So please feel free to send me an email. And thank you, Josh, so much for answering all these questions and for your passion around this subject. We really appreciate having you on today. And it looks like someone had asked one last question. Do you know if protections from arrest for those calling 911 related to an overdose extend to undocumented individuals? Great question.
Yeah, wrong guy for that. I'm not I'm not gonna provide the legal advice around that. Sorry. Yeah, I don't know.
I'd be happy to look into that. So again, if you do want to send me an email, I'd love to look into that for you. So yeah, thank you so much, Josh, for presenting. I just want to throw our screen up one last time. Please be sure to take the evaluation. I will be pasting the link in the chat, and it helps us, like I said, just to better understand how we can serve you with our trainings. And then we have upcoming training opportunities on our website. Some of those are listed here, and we have the links on our site for registration. So if you're interested in any of those, please visit our website to register. The link for trauma and substance use disorder is not yet on the site, but I will be sending that out to all attendees in the next couple of weeks here. That'll be our next topic in our series. And thank you so much for speaking and for joining us, everybody who attended. We really appreciate that. And I hope you all have a good afternoon.